Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
We would like to direct your attention this morning to the region of the mouth and jaws. This is an area that is frequently neglected in routine physical examinations, and it is a storehouse of important information, and we hope that we will encourage you enough this morning to approach this region with inspiration and with a keen outlook for recognition of abnormalities. It's certainly the most accessible of body orifices, and therefore it is readily examined, and if it is properly approached, it will yield a great deal of significant information. It is true that the dental profession regularly examines this region, but it is important, I think, for you to understand at least the common garden varieties of lesions in this area so that there can be a better understanding between the professions of dentistry and medicine for improved health care of the patient. It is then with some of these things in mind that we will try to emphasize the significance of this area. Insofar as the yield of findings in the oral cavity, there are few areas in the body which are subjected to the continuous insult that oral mucosa sustains. There is constant mechanical, thermal, chemical irritation going on, in addition to a flora which, as you know, is inclusive of pathogens. Therefore, this is a region in which, if there are reductions in tissue resistance, the oral mucosa frequently serves as an index of this lowered resistance. Also, it's a region in which there are many reactive lesions from local injury. With this in mind, then, we will approach the patient, and we have with us this morning Dr. Booth, one of our residents, to serve as the subject for the approach to oral examination. History has become a part of the framework for examination in your approach to patients, and certainly in the region of the mouth and jaws, history has its important baseline reference. The oral habits of the patient should be known insofar as this relation to additional irritation is concerned, their use of tobacco, their oral hygiene, their dental professional supervision. These things should be known. Their histories of previous dental care. On the other hand, history often will be deficient insofar as symptoms are concerned because the oral region is so constantly subject to minor insult. The symptoms of pain and the like are apt to be transient and may well be ignored. Also, certainly insofar as detection of malignant changes are concerned, the most common malignancy of the oral cavity, squamous cell carcinoma, is usually very limited in the symptoms which are presented. And this is true of other oral diseases. Often the symptomatology is minimal. So we will want to gain all of the information we can historically, but we should be stimulated to careful inspection and palpation of oral structures because of this often lack of symptomatology wherein important lesions are present. In the oral examination, it's well to have the patient seated and the head supported, as you have noted here in the case of Dr. Booth. The examiner will have in mind, as in all areas of physical examination, a thorough, orderly, methodical approach that is organized and is complete. We do need for this examination a minimum of equipment, which we may look at just now. We have to gain access to this region, and we therefore will need armamentarium for retraction of the lips and cheeks and some source of illumination. So a good pen light with fresh batteries and new bulb, which is a rare entity in this hospital, some tongue blades for retraction of lip and cheek. Some form of probe is particularly helpful in the oral examinations to examine the area of the gingiva and the epithelial attachment of the gingiva. And this may be in the form, any form of a small sound. This happens to be a lacrimal probe. Something of this nature may be available, wherein the small dental explorers, which this is, may not be available to you. But some form of sound to demonstrate the integrity of the gingiva and to be available for the examination of the areas of salivary duct orifices and perhaps the sounding of any sinus tracts that we'll speak about a little later. In addition to that, for some of the inaccessible regions not otherwise viewed, a mouth mirror is advantageous. For your own protection against sharp tooth edges and the pathogens of oral flora on lacerations and so forth of your own hands, and also for the increased comfort of the patient during palpation, some form of finger cot or rubber glove is advisable to conduct the palpation aspect of the examination. Wherein palpation will be required, some form of lubricant may also be advantageous to gain access to this region. Often the commissures of the mouth, particularly as we approach this season, the vermilion of the lip becomes frequently desquamative and sometimes fissured, and therefore it's well to ease the palpating stretch that you place on the lips at their commissures, which otherwise would crack and become sore. So some form of lubrication will be beneficial. Now then, let us return to our patient for regional examination, and we will lubricate the lips slightly, and particularly in the commissures. And if you have a patient, particularly those who have psychological barriers for oral examination, and this is something that you may find, the patient, when you begin to look at their mouth, may immediately start to gag, and you may find that local anesthetic ointments spread on the oral orifice will be helpful for your examination and gaining of access. So we will now, with this lubrication, look carefully at the lips in repose, and if we can come in tight on them, we'll see in this younger person the striae of the normal lip. These are vertical, and they are indicative of health. In older age, they become erased as atrophic changes affect the vermilion of the lip. This is tissue, of course, that reflects such a rich capillary bed that it is helpful and indicative of anything that induces hypoxic change insofar as its coloration is concerned, so that your polycythemic patients and the patients who have anything interfering with normal oxygenation of normal quantities of hemoglobin will see changes here. We will examine first, and then we will palpate. And this follows regionally about what you have learned so far in all other regions, having a keen eye then for all of the recesses of the oral cavity. We'll begin with the patient's jaws closed. And this is one thing that you might keep in mind, that the oral cavity, the buccal orifice, is, insofar as a pouch is concerned, is on the basis of the buccinator. So with the patient's mouth stretched open widely, the buccinator, the cheek, is on a stretch, and you cannot, when they are open widely, get into the recesses of the fornices around the buccogingival sulci. So you will not want the patient at maximal opening excursion, but you'll want them only partway open as you examine the vestibular areas of the oral cavity. We then first will reflect the lips, and we'll ask Dr. Booth again to close, and we'll particularly now examine this moist surface of the lower lip. This is maintained moist, you'll recall, by the accessory salivary glands that so diffusely and generously are immediately in the submucosa. These are subject to abuse and injury, and this is the most common site for the retention cyst known as the mucocele due to the obstruction and occlusion of the ducts of some of these accessory salivary glands. Having examined then the depth of this vestibule and everted the upper lip in similar fashion to note any abnormalities in the reflection of mucosa there, we'll next then direct our attention to the buccal mucosa. And we'll ask to have our patient open part way, and we'll make an effort to retract the lip. Close a little bit, please. That's fine. And we'll try to get some light in there for you to visualize the several things that are available in the buccal mucosa which we should be alert for. There is, of course, adjacent to this second molar, the parotid duct orifice, which we will see right here. Its normal secretion of serous saliva can be viewed, and we can, with the opposite hand, oft times, there I think you can see the drop of saliva. I'm milking the parotid from the angle of the mandible anteriorly along the course of the duct, and we did have I think you caught a glimpse of that, although my retraction is not too good. Let's open a little wider, please. That's fine. Now, as we're looking back, we see behind the molar teeth the tuberosity region of the maxilla, and we see way back up in here lateral and inspect that recess, which is one of the areas that can be neglected. We would then carry this same inspection around the entire oral cavity and noting the similar changes on the other side. The buccal, just turn your head a little to the left. That's easy. That's it. We can see, again, these similar structures. Now, the buccal mucosa, as we look at it far back, there's a little white ridge that comes along here, and this is in the area of the occlusion of the teeth. Some people have habits of cheek chewing, and they will have roughness of the mucosa in that area. It is also a site of insult. It therefore is a site of occasional reactive lesions and, of course, the possibilities of more important lesions. Let's then next, if you recall our sequence thus far, we've looked at the lips, lower and upper. We've looked at the buccal mucosa and the vestibule of the mouth, all the lateral structures, and that'll be 1, 2, and next we'll look at the palate. And we'll ask the patient to tip back a little bit to examine the structures of the hard and soft palate. We'll go over these areas again in palpation in a moment, but on inspection you see completely normal configurations here. You see the rugae, which are the specialized mucosa with submucosal fibrosis, which leads to these ridges that are normal in their configuration of the anterior palate. You will also see here where I've directed the light of the mirror, the anterior papilla over the nasopalatine duct and foramen, and it is this region which occasionally gives rise to cysts in this region, which may give prominence. This is also the region in the hard palate of a very common entity known as Torus palatinus that we will show you in another patient just a little bit later this morning. We'll then examine the soft palate, and we'll have the patient bring his head down just a little, keep open widely. We'll slightly depress the tongue. We can see now, head down a little farther, that's fine. Now we're beginning to see the normal mucosa of soft palate, and we'll ask for phonation to observe the retraction of the palate with an ah, or a high E. Open widely. Ah. Again. I'm afraid you're seeing my thumb. That's fine. Let's try that again. Ah. Again. You see the normal movement of the soft palate, which is symmetrical. It's being elevated by the slings, the musculature that you know about. It's being retracted upward and backward in order to close with the pharynx in the normal velopharyngeal valve. Now then, we have examined, we have looked for any alteration, signs of inflammation or ulceration of the oral mucosa so far, and we will stepwise next go to the tongue. And for that, we'll have the patient's head a little forward so that we can examine the tongue and the floor of the mouth. We first of all will ask the patient to protrude his tongue. And of course, insofar as your knowledge of neurologic examination is concerned, you're noting the symmetry of that protrusion insofar as the possibilities of any hypoglossal, any motor impairment that might be observed. We also were looking for motor impairment when we asked for the soft palate movement. Now we've examined, let's have your tongue forward again, sir. We examine the dorsum. We see the normal distribution of papillae here, which you recall are filiform and fungiform in the main. The circumvallate will be farther back, and I hope we'll see them in a moment. We also will examine the foliate papillae next on the lateral border. The lateral borders of the tongue are important regions. These are also recipients of a good deal of accidental trauma when they get caught in between teeth. And we'll have you open now. You note we're taking some gauze. Project your tongue, please. We're going to use gauze to hold this tip of the tongue, and we're going to retract it. Your head back a little. Fine. Now, if we are looking, we're looking at the posterior lateral border of the tongue, an area that is frequently neglected, an area which incidentally is very well innervated. You can see the little nodular surface that is here at the root of the tongue. Often this is subject to some injury, and the patient will come in complaining of such soreness. You will look back there and you'll see these elevations, which are the foliate papillae. Occasionally there are varices of veins in that region, and this is, however, normal, and you can best judge its significance of changes and elevations back there through comparison, of course, with the opposite side, which you've come to learn as an important consideration. And we see on the opposite side identical surface changes. We'll next turn to a very neglected area, and that is the floor of the mouth, to inspection. Patient sticks out his tongue. You look at it, things look all right, and you may forget this ventral surface of the tongue and the floor of the mouth, which are extremely important. You can ask the patient, and this is not an easy thing to do at first for a patient, ask them to open their mouth and try to touch the roof of their mouth, the anterior hard palate, with their tongue. Try to open again to do that. And here we then see the entire ventral surface with its venous distribution. We will see the elevation then of the sublingual glands that come rolling up as the mylohyoid lifts the tongue forward. We will inspect for all of these areas for the possibilities of any break in the normal surface mucosa. You can see the dilatation of the superficial venous channels in this, under this thin mucous membrane. This is another site for retention cysts, incidentally, so-called ranula. Now, with your head down, just a chin down a little farther, I guess we cannot quite make out the caruncles of the submaxillary ducts, but of course they are immediately behind the central incisors, and we will then be able to again examine the consistency of the salivary secretion from the duct orifices here. We now have then completed a regional inspection. We will carry this examination back to the pharyngeal area and fauces, which don't show very well here, with the help of mirrors, which ordinarily with these mechanisms do not completely help us. We'll next look at the teeth and gums and occlusion. We'll have you close now You can see the gingiva that are normal here. Palpate them. They are not yielding of any inflammatory disease. The probe that we mentioned before can be inserted at this free gingival margin wherever there is a sign of inflammation that might be representative of one of the most common lesions, that of the so-called pyretic or periodontal disease pocket, in which this normal resistance of epithelial attachment is not present. We'll next ask the patient to go through some excursions of the jaws. Just open now and close and protrude and back. Now one side and the other. We look for these excursions, making sure that there is a normal muscle control insofar as the ability of the patient to open. There are many things that alter this performance in the nature of trismus, in the nature of asynchronous neuromuscular problems for the mobilization of the mandible. We would then next proceed sequence-wise, since we have examined these oral structures through inspection of all recesses. We've done it in a stepwise fashion. We would next go through the zones that we've just inspected with palpation. This is best accomplished bimanually or between the thumb and finger. We would examine, for example, in palpation, the full thickness of the lip. Here we occasionally will find some fibrotic nodular submucosal areas in the zones of accessory salivary glands. We will next palpate the upper lip, similarly feeling for any zones of induration. We'll carry this back through the vestibular area, again supporting the skin of the face and having between the palpating finger the full thickness of the cheek and lips. This would be carried on, of course, bilaterally. We then would go to the region of the palate and palpate in this same area for any areas of abnormality to the palpating finger on the basis of morphology or any zones that are tender. If you get into a problem so far as gag reflex is concerned, you may wish to employ topical anesthetic agents for this stage of the examination. The tongue we would again have protruded, if we may, your tongue forward, Doctor. And once again we will grasp it in gauze, retract it, and go through the same palpation of this organ. The floor of the mouth would be next, and once again we would support the tissues in the submandibular submental region with one hand while we palpate the region of the floor of the mouth with the other, with the index finger. And in this manner, then, we will be able to gain any index of abnormality that may be present in these structures. After the palpation, one should be alert for the possibilities of any hemorrhage that might have been created within the oral cavity through the palpation, since occasionally very remote regions that are granulomatous in surface and actually may be neoplastic may give rise to some bleeding. So if bleeding was elicited through your examination, you would trace down its source to see its area. The most common sources of bleeding are gingivitis, and we'll talk a little bit about the variations in inflammatory disease in the oral cavity. On the other hand, a small lurking carcinoma in some recess also may be one of the causes for such bleeding that follows examination. One thing that I did neglect, since this mouth did not present it, is the question of appliances, dental appliances. These obviously should be inspected as to their function and also should be removed, since the areas beneath such appliances often are most significant. Now that we've looked at these regions and gone through them stepwise, let's just take a look at a couple of common garden variety forms of pathology that you may see with the help of some slides. One question to be considered is gingival pigmentation. Now, we saw the rather normal color of gingiva in our patient here, and here you note a good deal of melanin. Now, you have learned that perhaps brown pigmentation may be indicative of adrenal insufficiency of Addisonian type. It also, and far more commonly, of course, is on the basis of racial distribution of melanin. And this is what we are looking at here, a completely normal gingiva with racial pigmentation. Let's look at the next, please. Here we would see enlargement of gingiva. Now, what does this mean? This enlargement can mean a number of things. There are familial tendencies for gingival fibromatosis. There are enlargements that are associated occasionally with vitamin deficiencies, such as ascorbic acid deficiency. There also are enlargements that are on the basis of blood dyscrasias, and most commonly monocytic leukemia. Another thing that induces this peculiar enlargement of gingiva that is important for you to recall is anticonvulsant medication. About half the patients on Dilantin, which this patient had, manifest gingival hyperplasia to this degree. The next, please. Here is perhaps the most common sequela of the most common of dental diseases. This is the sinus tract or parulus on the attached gingiva, which will yield purulent exudate and is indicative of an abscess tooth that is exteriorized and is draining through the gingiva. And the next lesion will show something that you should also keep in mind. When patients present facial and cervical, areas that resemble chronic furuncles that do not clear, do not excise, cauterize these things until you are certain of the possibilities of odontogenic infection, because drainage may be established from these areas not only within the mouth, although this is more common, but these sinus tracts may develop in the areas of the face and neck. The next will show a radiograph of this patient we've just seen, and we'll talk a little about dental x-rays later, but suffice it to say that this area at the root end, where bone has been destroyed, is the origin of the infection that we have just shown in the sinus tract formation in the chin region of the lady that was just shown. The next will show us another swelling that is obviously inflammatory in this patient, and I hope that as we look at a couple of neoplastic changes later, you'll keep this in mind. There's very little difference oftentimes in what is inflammatory and what is neoplastic in the involvement of oral tissues. This enlargement is also painful. It's inflammatory, and it arises from the other most common oral disease. We mentioned dental caries, and the other most common form affecting older individuals is periodontal disease. And so this is another of the forms of abscess, and if you push on this, you'll get a flow of purulent exudate around the free gingival margin. Let's look at the next momentarily. This patient would certainly have gingival bleeding. They also would have a marked malodorous mouth, and if you touched these free gingival margins, they would spontaneously bleed generously. This patient will have some systemic inflammatory response in the form of fever and malaise, and this is Vincent's infection, the most common form of gingivostomatitis, which perhaps you've had reviewed for you bacteriologically and know a little about its treatment. Its treatment, I would emphasize, must be thorough and comprehensive and dental. Antibiotics may temporarily get this patient out of some of their symptoms, but it will not clear until adequate dental therapy and oral hygiene is restored. The next gingival change looks a little bit similar and is another very common change within oral tissues. In this instance, you notice that the free gingival margin is not sloughing. It's still intact. It's red, and there are a few small ulcers. There's one here and there's one up here. If we examine the rest of the oral mucosa, we'd see additional ulcers, and this is viral stomatitis of herpetic type, and it is again, the other most common form of gingivitis, usually affecting children, and is a common sequelae of the various forms of eruptive fevers that are then followed by herpetic stomatitis. Let's look once more at another of the areas of ulceration. It's quite obvious that within the oral cavity, which is moist surface and which is constantly taking this beating that we talked about, that vesicles would be few and that ulcers would be the most common lesions that would rapidly form. And differential diagnosis of ulcerative lesions is one of the most difficult areas of oral diagnosis. This particular ulcer is once again on the basis of viral etiology. The next. We mentioned that the oral mucosa gives many reactive lesions to insult, and this is such a lesion. This thing arising in the gingiva is a fibrotic reactive so-called blastomatoid lesion, which is just the result of overzealous repair in this zone where blood supply is so good. It obviously must be excised and examined to prove that it is this type of lesion, but it is the common type of reactive fibroepithelial change that is papillomatous that we see frequently. Here it is in the gingiva. The next, we'll show it in the cheek area. And again, this is merely indurated submucosal fibrosis. It is a fibroma on an acquired basis. The next. Here we have an area which will show us, again, a region that is often neglected. And here you can see the accumulations of dental calculus. This is the salivary calculus that is often related to the inflammatory diseases, and you will find it in its greatest quantities adjacent, of course, to the orifices of the salivary duct, the submaxillary duct, and the parotid duct. With this situation in mind, I think we'll leave the slides for a moment to talk a little bit about this relation of salivary calculus to periodontal disease. It is an irritant. It does need to be removed. It cannot be removed through routine oral hygiene methods. It's one of the reasons for periodic dental care. When you observe it, it can be confusing. It can be mounded up so high that you can hardly see the teeth. It may actually cover the mandibular teeth. Let's look at a couple more illustrations of common entities, and then we'll turn to our next patient. There are a number of things that disturb the odontogenesis, but that is perhaps best known to you is shown here. And when these patients hit the hospital, why, almost all departments go into a little bit of ecstasy because somebody wants to show off the saddle nose and somebody wants to look at the saber shins. And within the oral cavity, you recognize a Hutchinsonian incisor, which is classical here, barrel-shaped notched incisor edge, and the so-called mulberry molars, in which there is hypoplasia of the crowns posteriorly in this form of congenital syphilis. The next. The tongue will yield many things. We cannot devote much time to it. This is a normal variant, which you should know about, so-called benign migratory glossitis or geographic tongue, which just shows some changes in desquamation of the dorsum epithelium and the papillae. The next will show another variation in papillae, which may be present where irritants are present and where oral hygiene is not to be found in total oral neglect. And in this otherwise also hairy individual, you see the labial hirsutism out here. This is the black hairy tongue as well. This is merely the enlargement of keratotic elongation of filiform papillae, which trap and accumulate debris and give this appearance. Let's look once more at the next entity, and these deal with keratotic changes. And these are the things that you'll be particularly alert for, the white patches. Now, white patches in the mouth mean many things, but among the things that they can mean are keratotic changes and also loss of the normal pattern of epithelium, which brings on a so-called dyskeratotic change in what you perhaps already know as true leukoplakia. This is a precancerous lesion. The percentage of white patches that are truly leukoplakic is small, but it nonetheless is a point, and particularly where they are thickened, where they are fissured, and where there are associated ulcerations. Let's look once more at the next. Here is another white patch that is not leukoplakia. It is often confusing. This is so-called lichenoid, and I think you can see it looks like a little milk web infiltrate submucosally. It's not heaped up, and it is lichen planus, a benign mucosal change. The next. This is true leukoplakia, true smoker's patch, and is a type of thing that you want to be looking for. And the next will show us this area that we mentioned that can often be neglected, the floor of the mouth and the ventral surface of the tongue. And this is a squamous cell carcinoma, totally asymptomatic in this individual, picked up on routine examination. I would like next to return to the examination of a patient and introduce to you a patient whom I had the good fortune to only meet yesterday. This is Miss Margaret McKitchie, who is an administrative assistant in the School of Public Health. And her name is McKechnie, and I mispronounced it. She has a good Scotch name. She has been kind enough to come to us today to demonstrate to you another of the very common changes that occur within the oral cavity. Approximately 20%, 1/5 of the adult population, manifests some form of exostosis of the jaw region. And this patient has known for a number of years that she had something wrong on the roof of her mouth, mainly because it has become irritated from time to time and may remain sore, limiting her food intake for periods of occasionally 5 days to a week. She has then followed this with a remission, only to have it again irritated. This will demonstrate, I believe, quite well the entity known as Torus palatinus. Could you open widely, please, now? And we'll have your head back just a little more. I shall try to get enough light in here to demonstrate this for you. And if we can come in tight on it, you'll see why she came to see us yesterday. Since there is an ulcer that is on the anterior pole of this, would you open widely? Notice what an interesting configuration this has. You're getting a good look at it. You are seeing a well-circumscribed and healing ulcer of this lobulated mass. This is bony. It is stony hard to the palpating finger. It is, you can see its configuration into quadrants in this particular pattern of lobulation. They are not always lobulated in this fashion. They are attached to the midline hard palate. And their significance lies in this repeated ulcerative tendency when they reach this size, and also in their limitations to what can be accomplished in the way of dental prosthesis when such growths are present. We have arranged, because of the tendency for this to remain irritated from time to time. The mucous membrane, of course, is thin over this area, and so trauma will take its toll in ulceration. This lady has a very well-kept mouth. She has fine occlusion. I'm going to change the position of her head to show you the other. You can close your mouth, please. The other most frequent site, if we might have your chin right down on your head, on your chest, please, and open again widely. The other most frequent site for this same type of exostosis. Thank you, that's good. You can see the, again, lobulated prominences on the medial surface of the mandible adjacent to the premolar teeth, and this is representative of so-called torus mandibularis, a similar osseous change. The etiology of these, incidentally, have not been as troublesome to her as the projection in the palatal area. I think that, thank you so much for coming in to see us, and I think with this we'll look at another of the aspects of examination that relates to x-rays. If we might consider for just a moment the correlation, and of course we have gone over we have omitted history, we have dwelled on steps of examination, and we have not included laboratory data, but just a brief word relative to radiographic diagnosis of oral structures. Dental x-rays, as an example shown here, are extremely detailed, mainly because they have a very happy quality of having the film immediately adjacent to the part, and therefore distortion is minimized and there's not as much superimposition, and therefore we get the surprising detail of trabeculation of bone. Here you see this white is a filling area, you see pulp involvement, and here we see a lytic lesion in the apical area. Let's look at just a couple others insofar as other revelations of such films are concerned. Here's a lateral mandibular film, again showing the distribution of inferior alveolar canal. And once more, they will show unerupted teeth with the last of these. Do we have one more x-ray or not? There we are. And this, of course, in dentition and sequence of dentition, often it is the last teeth to develop that get run out of space in the jaws, so third molars are the most frequently impacted, and this radiograph shows is the only revelation of this otherwise asymptomatic condition, which can give rise to difficulty and is well to remove. Now, there are some considerations of this area that I'd just like to emphasize as they relate to special circumstance of trauma. And for this purpose, let's look at a dry specimen for just a moment. Because of its prominence, the facial skeleton is frequently subject to trauma, and so we find in this region lacerations which go down to bone, we find fractures, and we find dislocations. In the examination of this region following injury, one, in addition to palpating, attempts to manipulate the structures in order to demonstrate the integrity. For example, the integrity of the maxilla to the cranial base and to the rest of the facial skeleton is best demonstrated by grasping the sections of the alveolar process and demonstrating that they are indeed intact. This can and should be done bilaterally to detect teeth that are hypermobile and possibly avulsed alveolar process fractures, as well as unit fractures of the entire maxilla in which the entire upper jaw is moved around, much as an artificial denture can be moved up and down. Palpation of the orbital rims, the nasal bones, and so forth is also in order, as well as palpation of the normal landmarks of the maxillary region. In the mandible, likewise, demonstration of an intact mandibular arch, this unique bone, is important. You will on occasion be called upon to assist a patient who has dislocated the mandible. Dislocation, you recall, anatomically arises when the jaw is opened to a degree that the condyle slips anterior to the eminence in this fashion, and we therefore have a dislocation, and when the condylar head is anterior to the articular eminence. Now, insofar as the patient's complaint is concerned, this patient cannot get their jaws together. They can't close their mouth. They're out like this. I just accomplished the bilateral dislocation. We had a unilateral there for a moment. But you do see the head of the condyle here is out of the fossa, and it is anterior. It should be back here. It's forward. The mandible is in a protrusive position and cocked open. How are you going to help this patient? Well, it depends on when you arrive on the scene. In this position, the heavy elevators, the muscles of mastication, promptly go into spasm, and they will resist the efforts to manipulate this down and back in order to accomplish the reduction. So the intervention will depend a good deal on the duration of the dislocation. If it is immediately out, you can put it back much more simply than if there have been several hours of muscle spasm. But to manipulate it, whether you require anesthesia of various sorts or muscle relaxants, the manipulation is the same, and it makes the effort to direct the mandible first downward, and then once you clear the articular eminence, it will quite promptly slip back. And in that manipulation, you keep your thumbs well back on the ascending rami, and you avoid getting them interdigitated here because these jaws go back in a hurry. These will be some of the considerations. You'll see some patients who have trismus, who can't get their mouth open. This may be on the basis of decerebrate rigidity or a number of things. If, incidentally, it is on the basis of hysteria, you may be able to apprehend and determine this. If there is some additional question, you may use other mechanisms, such as blowing in the external auditory canal, which will promptly, incidentally, if a patient is locked on you, that's a good way to have them let go, is to blow in their ear, a small trick of the trade. Another of the things that you may find patients who are biting down firmly, and you can't get into the oral cavity, and you may want to secure airway, remove foreign body, etc. And it may be you may just be able to admit a tongue blade or two. Getting it back, you have a lever that you may, instead of breaking that off, you may slip in another one. And once you have two tongue blades between the teeth, then you're in ideal advantage to slip additional tongue blades in between in a wedge fashion, which will progressively open the mandible. You can slide these back and add the number of tongue blades required to get the mouth open to retrieve a bridge or something that may be in that vicinity. So much then for this area after the problems of injury and trauma. And we hope that in viewing an area that is subject to neglect, to show you its recesses, to show you the techniques of making these areas visible and accessible to both inspection, palpation, that you may take a greater interest in this particular body region. If there should be a question, I think we have a minute or two, and we'll stand by for them. Is there? Yes. If we can get Dr. Booth quickly back in the chair, we can. This is done just on the basis of your knowledge of the salivary gland anatomy. In order to visualize the quality of the salivary flow, we may not be able to demonstrate this entirely. You'll recall that most of the parotid is retromandibular. It's back here and is distributed. And as you're going to milk this gland, you want to have one hand get in behind the mandible, behind this ramus, and bring it forward in order to manipulate and compress the parotid, milking the secretion outward. Now, before you view this, try to open again, Doctor. And turn a little to the right. We may not get this fully in view for you, but it's best to first dry the adjacent mucosa. I think you can see that now. Now we'll see if we can demonstrate this. If he's thinking about lunch, we'll be able to. There. Oops, afraid we missed our drop. There we go. Once again, we'll dry it. And we see you can certainly see the papilla, and we'll see if we can get another flow. Now, in the submandibular area, we will again get the hand well beneath the inferior border of the mandible. My right hand, let's come up a little. Can we come out a little, not so tight? My right hand is beneath the mandible, and the fingers are in the region of the submaxillary fossa. And again, we would have the chin down. We would dry this region and usually isolate one side. And you can't see this because the teeth are in the way, but I can see it. And again, we'll milk by pressure in the submaxillary fossa, and with another finger back toward the hilus of the gland, milk forward. And in that fashion, you can demonstrate the flow. And of course, if there are obstructions of various sorts, atresia, siloliths, and the like, they'll be evident to you on the basis of absence of flow or a disturbance in the quality of the secretion. I hope that now, as far as the sublingual gland is concerned, you recall it does not empty through the duct itself ordinarily, but has many openings in the floor of the mouth.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.